Yeah, 2 o'clock on my, sorry, 1 o'clock on my watch. So let's get going. I think people will still continue to be coming in, but in the interest of time, I think we'll get started. So welcome everybody to the National Primary Care Discussion Group for Personalised Cancer Care. This is our first meeting where we've transferred over to Wessex as the new host. So welcome to people who are here. I think in the transition, because of GDPR, we had to get people to re-sign up to the mailing list. So we may have lost a few people. So if you've got colleagues who are previously a member of the group and they're not here today, maybe worth passing on details around how to rejoin, and all that information is on the slides. So for any new people, we meet every 3 months. This group's very much a kind of discussion group, as it says in the titles. We really kind of value your input, your questions, your comments as we go through. So please use the chat, providing you can access it. And at the end of people speaking, we'll have opportunity for people to speak as well. Obviously, just raise your hands if you'd like to. And this group's kind of a national group. It's open to anybody with an interest in personalised cancer care out of hospitals, so primary care, community settings, and the third sector. It is informal. We really do welcome your input. You can see we're recording. So the plan will be to put the recording onto the new website, which I'll mention at the end. And if you are tweeting, you can tag the Wessex Cancer Alliance, and the Wessex Cancer Alliance tag is on that slide at the bottom. So just a few kind of usual ground rules. So you can mute yourself if you're not speaking. Once the speakers start, probably best to switch your cameras off, and particularly if you don't want to be in recording, make sure your camera's off. We use the chat, so I'll try and monitor it as best I can. I can see it, which is good, because sometimes the slides obscure the view. As I said, we'll use raise hands in the speakers to start off any discussion. So with no further ado, I'm going to hand over to the first speaker. You'll notice there's a bit of a Wessex theme today. It's really by coincidence, really. This remains a national group, but our speakers today are from Wessex. So I'm handing over to Amanda Cummings from the Right By You project, and she'll introduce herself and kick off. Thanks, Amanda.
Okay, thank you. I've taken control, so hopefully this is all going to work smoothly. Okay, so hi everyone, my name's Amanda. I am the project manager for the Right By You service with the Wessex Cancer Alliance. And I'm going to talk to you today to tell you a little bit about the reach and the scope of the service, and then focus on some of our findings from an evaluation that we've done, and also some commissioning work that I've been doing around inequalities and the kind of financial impact of the service. Okay, so I know that you have had some presentations on Right By You before, but I thought I'd do a very brief bit of background for those of you who are not local and who have not heard of Right By You. So Right By You is a community outreach model of care that was developed back in 2019 in response to a funding call from Macmillan. The service started in Southampton City in 2020 and in Portland at the end of 21. And the team have supported over 700 people so far. So Southampton is a port and university city, has a population of 250,000. It's about 2/3 white British, but quite a range of ethnic diversity, with actually the highest levels of homelessness in Hampshire. And the team here is larger, so we have 4 CNSs, 1 mental health practitioner, and a pathway navigator. And Portland is much smaller, so it's a tide island right at the southern point of Dorset. Has very high levels of deprivation. I think only something like 0.3% live in the top 2 quintiles. And it's served just by 1 GP practice. It's also home to 2 prisons. So, and they have a team of 2, so 1 CNS and 1 support worker. Sorry, my scrolling through is not working. So the service delivery model it's difficult to explain because it's also quite unique depending on the population. But essentially, it's a model that's delivered by experienced CNSs and cancer support workers who have enhanced psychological training, and their role spans across primary, secondary, and community care. They do repeated health needs assessments with people and provide psychosocial intervention. They also do things like symptom side effect management. They provide advocacy. They do self-management support. And it's really tailored to the needs and the experience of people with cancer. So it's for anybody diagnosed with cancer, their family, friends, and caregivers. And there is outreach support to some of the marginalised populations, which I'll focus on a bit later. So that includes the homeless community and the prison community. Service users tend to be supported in their own homes, and they can be supported face-to-face, by telephone, text, email, however they prefer. And it's for anybody at any point along their cancer journey. Okay, so I'm going to talk to you today about findings from two different pieces of work. The first is what we call a phase 1 evaluation, which was an external evaluation conducted by the University of Southampton, who I worked for at the time, so I was also part of this evaluation. And we collected service data, which really focused on the kind of reach of the service, the different methods of delivery, and trying to explain the kind of complexity of the service. And we also did interviews with 60 different participants. So that included staff who were delivering the service users, and then staff from primary, secondary, and community care, as well as commissioners. Oh, I've just seen that someone says the slides aren't moving.
They're moving for me. I think because it's on PowerPoint Live, it might be that for people it's not moving, you've adjusted your settings, that you've got a different view.
Okay. They are moving for some.
Yeah.
Shall I carry on, or I don't know?
I think so. So I'll see if I'll put in the chat how to turn back to your slides sync with the speaker.
Okay. Okay, I'll keep going. You pause me if you need to. Okay. So the outcome of this evaluation really looked at the impact on patients and healthcare professional experiences. So the second part of the data collection has started since I've been in the job as the project manager. And this has really been focusing on looking at the kind of nature of the interventions that are being delivered and the implications for health service use. Because really now the focus is trying to get the service commissioned. So we've had to kind of really look at what the implications are cost-wise as well. So this slide just really to show that the difference in referrals to Right by You. So this will have changed over time because this comes from the original evaluation. So initially we found that in Southampton, the majority of referrals were coming from secondary care, whereas in Portland, more so from primary care. And I think that is to do with the setup that is just different across the two areas. The reasons for referral were often to do with people that had quite complex needs in any kind of element of their life. And also there was a real recognition amongst other staff about the limitations of time that they have and the environment. So people really respected the fact that Right by You can see people in their own home and really unearth things that they can't do within either a hospital or a kind of GP setting. And this again is from the original evaluation. So this is just looking at different service user characteristics. So you can see lots of different cancer types, lots of different people with different comorbidities. I think about 85% of people have other long-term conditions. Okay, and then the team are going in and identifying a wide range of different concerns. So psychological, physical, practical, a lot of family and relationship concerns, and other kind of informational and spiritual concerns. And related to that, they're providing a lot of support. So they do a lot of psychological support using kind of enhanced psychological techniques. And we now have Alison in post, who you'll hear from in a minute, and a mental health practitioner. So this has meant an increase in referrals for people with severe mental illnesses. So the team are also now providing mental health assessments and reviews. The team help with self-management plans. They do physical examination, history taking. They can prescribe. They also do a range of clinical assessments, so continence, frailty, falls assessments, and assessments for things like equipment. They do a lot of help with financial advice and signpostings. They do a lot of various financial applications. They do a lot of work around complex decision-making support, especially related to treatment decisions. And they have a lot of anticipatory communications with people. They also provide advocacy during different health and social care appointments, and they help to get service users engaged with other clinical teams, and this is particularly relevant in relation to palliative care. They also signpost and refer on to other services as and when needed, and they do provide bereavement support. Okay, so looking at the impact that this has on service users themselves, so they have they reported as part of the evaluation improved emotional and psychological symptoms, improved physical symptoms, and management of comorbidities. There was also evidence of improved engagement with care, so they were much more likely to comply with the care, and improved sort of knowledge and understanding of their cancer, and improved independence. They also avoided conflicting care or advice, so receiving potentially conflicting information, possibly from primary care and then secondary care. And there was also the prevention of having unnecessary or unwanted cancer treatment. And what was really interesting was the service users had quite a range of different experiences before Right By You came along. So some of them had quite good support already in place and others not. But actually, the one thing that everybody said was most fundamental was being really listened to and understood by someone. Over and above everything else was someone actually listening to them and understanding their needs. They were really glad of the fact that they could be visited at home, because they felt much more open to being themselves. They had a lot of confidence in the team, and they felt that the team were really responsive, so they always trusted that someone would get back to them. And they really recognised the team as being specialists in what they did. And the three kind of main areas on the left, emotional, financial, and family support, are the three main areas of support that they felt, that service users themselves felt were most important. And looking at the impact on the healthcare professionals, so this is people in primary, secondary, and community care who'd had interaction with Right By You. So because this is a kind of new model of care that's designed to address need, it actually led to improved job satisfaction amongst healthcare professionals, because they felt that their patients were getting the level of care that they really needed. There was evidence of improved knowledge and confidence, especially around pain management and end-of-life care. And within secondary care, there was an improved understanding of how cancer was managed in the community. And the secondary care professionals were also really aware that Right By You addressed things that they couldn't because of limitations in time and also the environment of the hospital, where people just weren't willing to open up and share what was really going on. So this looks now more a bit about the work that I've been doing latterly around the impact on health service use and some of the cost information. So the fact that Right By You is a community outreach team with advanced level CNSs means that they're proactively identifying needs within the community and managing them within the community without having to necessarily refer on. And this has led to a reduced sort of reliance on acute care. And they're also enabling carers to continue to care by the support they're giving to them. So it means that, more patients are able to stay at home. And the fact that they're doing anticipatory care planning means that they're often preventing care needs escalating to a crisis point, again, reducing the reliance of people on kind of unplanned care. And where needs are escalating, generally that because their kind of support is quite timely, it means that they're not reaching the level they potentially could do without their support. So this is a really horrible big table, but this is some of the work I've been doing around cost, which always feels really horrible, but because of commissioning, we really need to show the impact that the service is having on cost, really. So as part of the data collection, the team have been asked to look at what services they felt were being avoided as a result of what they were doing, to try and demonstrate the kind of efficiencies that this is having in the health service. So if you look at the top bit, this focuses on primary care. So we've got number of GP appointments, home visits, practice nurse appointments, and I've used a number of different kind of NHS tariffs to try and work out the costs. So I've included a minimum and a maximum just to, you know, we can say it would be roughly within this range. And so then at the bottom, so this table is data collected by the Southampton team over a period of 2 months. And they were only able to collect data on 40% of their kind of workload. So I've scaled this up to show 100% of service delivery. So the potential minimum savings would be 80,000. And the cost to run the service during this time, so the staff costs, but also the sort of facilities and other costs, would be 55,000. So there's a potential cost saving of around £25,000 over that 2-month period. So a lot of my work now is talking with commissioners and things and looking at these costs. I've also been trying to show how I've just seen a question pop up, but I'll come back to that at the end because I'm nearly done. How the service is really facilitating integrated care. So the team are constantly providing kind of updates to professionals, and they kind of act as a conduit, but also create these relationships between primary and secondary care. So generally, you've had improved communication across all of the care sectors. They also liaise with other services for advice when needed, and they're really bringing in other services at the right time. So there's a real impact about avoiding duplication, and bringing in the right services at the right time mean that people are often getting their care quicker. And again, there's a reduction on the kind of unplanned care use. They also draw in other supports. So I think when they refer on, about the 4 out of the top 5 services they're referring to are charities. And for commissioning, this is quite important. So I think about 85% of the services they refer to are non-NHS funded. So it's about bringing in those other services that can help the patient, but reducing the kind of cost implications for the NHS. And also professionals have said that because they know more about the patient because of Right By You feeding back, they feel they're also able to provide more personalised care. So it's not necessarily just the team providing more personalised care. As a result of their involvement, everyone around is able to also, you know, personalise the care better. And the integration is multi disciplinary and cross speciality. So it's across health and social care, and it's also across specialities. So I think looking at the Southampton data, about a quarter of all the interventions, there was some aspect of care that was provided that related to something that wasn't their cancer, a different condition. I'm aware that I've only got 1 minute left, so I'm going to skip the quotes. So the last 2 slides are looking at the focus on inequalities. So we've been trying to show how the service is reaching kind of marginalised groups, because that's what it does really well. So in Southampton, the one of the real focuses of work is around homelessness. So homelessness rates in Southampton are high, and people experiencing homelessness because of the kind of chaotic nature of their lives, find it really difficult to comply with cancer management. So the team have established links with the Home as Healthcare, and they've supported over 17 users, 17 people experiencing homelessness so far. And I've focused in a bit on those with severe mental illness, and actually, so they have increased cancer-related mortality and less access to treatments. So these figures are actually higher now. I've redone some of the analysis now. I've got more data, but around a third of the patients that are being supported have a diagnosed mental illness, and 13% of those are severe mental illness. Okay, I'll skip on to the last slide. So this is the same, but looking with a focus on Portland. So Portland's quite unique. It's a completely rural location, and the very high levels of deprivation, as I said. So 99% of service users of Right By You live in quintiles 1 to 3, and 20% are unemployed, and nearly half live in the most deprived quintile. Nearly half of them live alone, and there's about a quarter have poor health literacy. So they're quite a unique population. And I'll just finish by saying that Angela, who's our CNS in Portland, has been doing quite a lot of work with the prison community. She's got really good links with the Verne prison on the island, and they're a really unique group. They have really limited access to primary care services. So they're a high user of emergency services, but also cancer is actually the second most common cause of death, but their access to effective care is really bad. They always have to attend secondary care with escorts, so they never have conversations on their own. Often their appointments are cancelled. They have to have escorts, so if there's not enough staff that day, they just don't get to go. They also can't have unscheduled phone calls, so they can't call a CNS, or the CNS can't call them, for example. So Angela is doing a lot of work of supporting these individuals in Portland. And I'm going to say, I think I won't bother with next steps because I'm running over, but yeah, any questions?
Thanks, Amanda. I think there was one question in the chat around your just how you approached it. I'm not sure what specific aspect Amanda was referring to. I just got a hand up.
Yeah, sorry. I realised I kind of threw it in there and never said what I was referring to. It's really around how you summarised the health service savings, the cost savings. It'd be really good if you could share how you went about that, and perhaps if I could contact you separately, because what I do is create little kind of case studies, and I think a case study on how you went about this particular piece would be useful and replicable across our full project or program. Sorry. So yeah, the actual summary that you've just shared is fantastic, and it's got me thinking loads. So thank you.
That's okay. Do you want me to shall I just briefly talk about how I?
Yes, please, because I think obviously as we come up against the next year's planning, this is on everybody's mind around where we can evidence cost savings, and if you've been able to create an algorithm that's been able to use that, that's great. Thank you.
Okay, so the way I've done it essentially was the team have been completing data collection forms for me. Yeah, I'm quite hated by the team. Always pestering them. So with a host of different questions, one of which is whether they believe that, so that they're asked to collect data on each kind of intervention that they provide for someone. So that could include a home visit, but then also includes the kind of communications they're having around that with other professionals. And then within that, I'm asking them a host of questions, one of which is, do you think any health services were avoided as a result of your intervention? And then there's a whole host of different things like the ones you've got listed here that they can tick. And then basically I'm using that data, and then I have done a lot of research to find out tariff costs for the various services. And essentially it's just a frequency of that against the tariff, and then scaled up to the amount of service delivery. It does look a bit different across both regions, which is quite interesting because the service is slightly different because the population is very different. As I said, this is Southampton one. So yeah, it's quite basic, and I know it's difficult because it's
but I think as people doing business cases going forward, having something similar to replicate would be really good. So thank you.
That's okay. I think it's really difficult because it's asking people to guess essentially, because we don't know, and how can we know? But there is really, I've done a lot of work of looking in different areas to try and find this kind of information, and this has so far been the best way to do it.
It's funny, I was having a conversation yesterday with somebody and on a similar point in that if we do personalised care well, which you are doing in any part of the service, the savings are not necessarily within that service, they're further along the pathway, and you know, so it's really hard to show, but I think this kind of gives us a bit of a gives us something to look at, which is really interesting. Thank you.
You're welcome. One thing that I was going to say, part of the work I'm planning to do is a bit around the impact on society as well, which isn't captured here. So, you know, we know that the team are actually helping people stay in work. So what's the financial impact of that? They're also helping either the service user themselves continue to be a carer, or other carers care for the person. So there's all of that in terms of financial implication again. Yeah, the impact is vast. It's just trying to evidence it is hard. Yeah.
Okay, thank you.
Thanks. There's a question in the chat I'm going to take, and then Jackie. So the question in the chat is around, I guess, commissioning and sustainability. So how is the service going to be funded going forwards? Can you give a short answer to that or not?
We don't know. Is the answer. So the service is the core service is funded until March next year. The two, so Alison's role and our mental health practitioner role are Macmillan funded for a year. So that is my job currently, is to try and get the service funded. So I'm working with the ICBs to try and get it funded. Hence all of this, the cost saving data, because that's what's so important really when there is no money.
I'm going to bring in Tanya, because it was Tanya that asked that question. She's got a hand up. Tanya, you want to say a bit more?
Hi. Yeah, thanks for that. Your cost savings are really interesting. The only comment I would make about them is, will those savings actually ever be realised, or is it just trying to take pressure off existing services? So, you know, your GP appointment, will that money actually be freed up? Or
I think this is part of the problem in terms of when I've had discussions with the ICB. It's like they're not necessarily going to see that money because essentially we're asking for a pot of money and we're saying it will save all this money, but it's not necessarily that they can just cut X number of posts in primary care, because we're saying it's going to this is
the frustration with it, isn't it? That
and I think it's, you know, it's very frustrating because everything you read this Right By You kind of is just everything that all the various policies are asking for. But I think because it's so complex, and some of the impact is a bit longer term.
But it's great to have the start of the model there. I'm sure that's definitely something that other services are used going forward. So that's great. So thank you for that. And it's a great service. Very jealous.
They are excellent. I think everyone is jealous and wants to work for them.
Well, thanks, Tanya. I'm going to bring in Jackie. Probably the last question for Amanda.
Yeah, it wasn't really so much a question, but one of the other cost savings that you might want to look at, Amanda, is medication savings. So particularly around the amount of psychological support that you're giving, you know, around sleep and all of those things. You know, if there's any way that you can see whether there's a reduction in, you know, antidepressants and other drugs and that, you know, and that will also give you a potential cost saving.
That's that's one I'd not even thought about. So thank you. Yeah. Thank you very much.
Brill. Okay. Thank you. Thank you, Amanda. Excellent presentation. You managed to squeeze in an awful lot of
sorry, I did rabbit on quite a lot there.
In a very good way, into a short time. So well done. Amanda, I can see you got your hand up. Is it a quick one?
No, it was a mistake.
Oh, sorry. Okay. I'm going to hand over to our next speaker, who is Alison Farmer, who is lead Macmillan CNS for psycho-oncology for Right by You. Have you got control of the slides, Alison?
Yeah, let's just test it. Yes, I have. I can't see anybody, so I'll answer questions at the end.
Okay.
Yeah.
I'm not seeing the slides moving at the moment from my end.
Okay. Has that moved?
Sorry, I think I had them, so I've come off them now.
All right, I'm going to reshare them. One minute then.
Sorry.
They're moving for me, but Amanda's weren't moving for me, so it's all a bit odd.
All right, I'll try and reshare them.
Okay. Shall I start just by introducing myself anyway?
Go for it, yeah.
Yeah, okay. So thank you for the invitation. As Amanda says, I'm Alison Farmer. I'm the lead psycho-oncology nurse for the Right by You team. And I just very briefly give you a bit of background. I sort of fell into a PhD looking at the psychological impact of breast cancer in about 1990. And taught psycho-oncology at Southampton University for 8 years before going back to oncology nursing at Southampton University Hospital, and noticed patients were, while I was hanging bags of chemotherapy, were in tears in the bed next door, and I didn't have 5 minutes to sit with them and talk to them. And so I wrote a job description and said, could I just support people psychologically? And amazingly, they said yes. I think it must have been in the 5-minute window. They had some money. So I did that job for inpatients for 8 years, and I've just transitioned to the Right by You team, which is fantastic because, as you've heard from Amanda, it's an amazing service, and I feel very lucky. And I think I'm very excited about this role, and I think particularly about accessing harder to reach groups, because one of my other roles is running or contributing to patient support groups and tumour specific groups. And, you know, you just don't see the demographic we're talking about in those groups. So there's a lot of work to do in that area. So I'm quickly going to introduce psycho-oncology, but not spend much time on that. And then just talk about a few tools I use for supporting patients. I'm not a counsellor, I'm not a psychologist. Even though my PhD was in psychology, you have to have a first degree to call yourself a psychologist. And I think that can be quite helpful, just saying to patients, I'm a nurse who helps with the emotional aspect of cancer. And I think also that it's really helpful being a nurse, because I think if you're supporting patients with cancer, it's really great to know about cancer. I think patients find that helpful anyway. That may be a discussion point. So psycho-oncology is the behavioural, social, psychological aspects of cancer that has its origins in the USA in the 70s. And prior to that, we were actively discouraged from asking our patients anything that might upset them. But it has now become an evidence-based subspeciality of cancer with its own body of knowledge, and is involved in all aspects of the cancer continuum, from pre-diagnosis right through to palliative care and survivorship. So what do I mostly do in my role? My role involves some psychological assessment, including history of mood disorder. And I think that's really, really important, because what I found in hospital was, in the patient's notes, I knew that they'd had an ingrowing toenail in 1962, but there was no evidence of their mental health history, their sectioning, all that sort of thing. It was incredible. It just wasn't seen as something that needed to be asked. And I think I'm still working on that. A lot of what I do is listening, validating and normalizing how the patient is feeling. So it's absolutely not rocket science, and it's what all nurses are able to do. However, for most of you and the other nurses I work with, there's a huge time constraint. So the clinical nurse specialists, although they have the skills, don't have that hour to sit with someone saying, I'm so sorry, this is rubbish. I might signpost people back to their CNS team. We'll liaise with them closely, maybe liaise on psychiatry or the community psychiatric team. complementary therapy, chaplaincy, tumour-specific charities, etc. Advocacy, really important. And I noticed, particularly when I was in hospital, if people came in with pre-existing mental health conditions, for example, I might talk to the staff about trying to avoid outlying them, having private side rooms, care plans, all those sorts of things. And this can be extended into the community, being that advocate for the patient. And I also do quite a lot of teaching, spreading the word about psycho-oncology, really promoting it, and including patient groups. So I think that's very important. And being in the Right by You team, I feel that accessing those patients in the group, we sort of spread the word about Right by You, and again create that link between primary and secondary care. So why do we need psycho-oncology?
Sorry, just to say, I don't think you've got control of the slides. So if you just tell me, I'll move them forward. I've been doing that. I just wanted to make sure that you knew that I was moving them rather than thinking.
Oh no, I didn't know. But I'm on the why do we need psycho-oncology? I am moving them for me. There's something funny going on. Anyway, at least you're there. So we need it because we know about 40% of patients experience psychological distress after a diagnosis of cancer, with about 15% having a major depression and about 10% a clinical anxiety. That is often, when I ask people how many, that they often overestimate the amount of psychological distress. But if you think about it, that's all patients, all cancers. So if you're 90 and you're diagnosed with a curable melanoma, but you've got heart disease, diabetes and arthritis, the cancer probably won't be the biggest problem for you. We know about 5 to 10% of patients report post-traumatic stress symptoms, and about 30 to 40% will have sexual dysfunction. And we also know that psychiatric illness is often not recognised. Our patients are really good, particularly when they go to clinic appointments, at putting on their makeup, their smart clothes, looking great. They're really worried about de-escalation of treatment. They want to be the good patient. They want to be coping. So I know you know this all too well. So what are the benefits of psycho-oncology? I think Amanda's covered some of this. Less distress in patients and relatives, improved quality of life and daily function, and really importantly, improved compliance. If we can tinker with the service just a little bit to help people attend for their radiotherapy and chemotherapy, to go with them when they're frightened. I've been into MRI scans, I've been into theatre, I've been into stereotactic radiosurgery, just to help the patient manage that treatment. That's really, really helpful. And I think a very, very important part of the role, because compliance in cancer treatment, as you know, is so essential. And also that cost saving to NHS, which I know Amanda has covered. And if I can prevent an admission due to a panic attack, because I saw them a lot in hospital, they would come into ED, middle of the night, chest tightness, pain, tachycardic. And I'd be asked to see them and I'd say, is it a panic attack? And they'd say yes. So helping patients manage panic, or helping patients, for example, come off their nasal specs they're on in hospital in order to get home, because basically their SATs are fine on room air, but they're very emotionally attached to those nasal specs. So psycho-oncology can help with all that, and even having those conversations about finishing treatment that can be particularly hard. These are just some of the implications of a diagnosis and treatment of cancer that you know about, and I'm not going to go through them all because you're very knowledgeable. I just want to mention loss, because loss is a huge thing when you're diagnosed and treated for cancer, and particularly loss of control. And that again is what I see to be an important part of my role, is to help give patients back some of the control they feel they've lost. And if that's by writing out treatment schedules, or if they're in hospital, showing them the quickest exit, thankfully nobody is left, or just laminating signs to go on their door. Please do not disturb, for example. Somebody asked me to laminate bugger off, which was quite fun. You know, all those things can really help a patient. So patients, particularly those with a pre-existing history of trauma, which are many people, sadly, will suddenly get a sense of being extremely unsafe and out of control again. So patients who are really distressed, often that is in the background. So what's normal? What are we not concerned about? Well, that initial shock, disbelief, panic and distress tends to be self-limiting and resolves over days to weeks with support from family and friends, if those people are around, and recurrent overwhelming emotions which pass. What we're more concerned about are symptoms that don't improve after a few weeks, patients who feel they have pervading negative thoughts and a sense of loss, sadness and hopelessness, or if they're maladaptive, so they're not coming to clinic, for example, because they're so low in mood or they don't feel worthy of treatment. And clearly, if the patient has any suicidal thoughts, we always take those really seriously, because we know that suicide is more common in patients who are diagnosed with cancer. So helping patients with that, you know, we've got Lewis on the team, who's the mental health practitioner, and very good links with community support groups, liaison psychiatry within the hospital, etc. So we can help patients. But, you know, it's important we're all skilled at spotting that. Next slide, please. So what predicts psychological distress? Because we can't see everybody who's diagnosed with cancer and is distressed, it's really important that we're all aware of what are the things that are likely to make psychological distress more likely in our patients. So those with high burden of disease and physical symptoms, those who report disease progression or lack of treatment options, where there's poor social support, because it's about perceived social support, isn't it? You can have 6 kids but actually not get any social support from them. Patients who feel they have a low level of self-efficacy, a poor quality of life, who are already anxious and depressed, and have previous use of mental health services. So that people who've had depression in the past are about, highly likely to experience another episode. So again, that's a really important question. And again, that history of trauma. So many patients will say to me, only my wife knows this, or I've never told anyone else about this. And a history of childhood abuse going back 70 years. Patients will tell me about that, and that what we know is that trauma impacts on a patient's adjustment to their cancer. So I'm really, really aware of trauma-focused care, really. And signposting patients to the right people to help with that. So we have a local Maggie centre, we have a psychologist there who does EMDR therapy, which is, fantastic for trauma. And we've seen some amazing results in these patients. It really helps them get through the treatment, because their brain physiology is already in fight-flight mode. And when the cancer diagnosis comes in, that sort of is all activated, and their alarm signals, their amygdala's going crazy, sending off alarm signals all the time. And, it's really important we recognise and help with that. So detection of distress. I tend not to use psychometric tools like the PHQ-9 or the GAD-7. I do occasionally, particularly if I'm referring to liaison psych, but normally in my work I'll just do a sort of clinical interview, really. And you can ask 3 questions. Are you depressed? Have you lost interest in things you used to enjoy? And are you tired? And that's 90% sensitive for clinical depression. And sometimes I'll just pick up their cup and say, this is a cup of distress, how full is it? And they'll say it's overflowing. So what matters is not really a number on a a sheet of paper. It really is the patient suffering to a degree that they want help, and we as health professionals can intervene. And what kind of help is wanted? This was a study by Mitchell. He found that understandably, it's mostly just face-to-face listening, validating, normalizing. Complementary medicine came next. If you're lucky enough to have maybe a charity or a complementary therapist in your hospital or practice, it's about illness information. Some people want to go to groups, not everybody, and self-help guidelines. And lastly, medication. Some studies have shown antidepressants are underused. They certainly do have a role in a diagnosis of cancer, but not everyone will need them. Sometimes the patients need a little more help. So I've done courses in CBT first aid and acceptance and commitment therapy, which has now been recognised by NICE as a really good therapy for patients with cancer. Lots of evidence behind it. And I just want to talk a little bit about some of the tools from that I might use. I don't consider that I do therapy as such, because sometimes I'm just meeting a patient on one occasion, but I can give them some tools for them to use themselves. So acceptance and commitment therapy is known as ACT, is a mindfulness-based, values-directed behavioural therapy. And it encourages patients to notice their thoughts and feeling and make room for them in order to live the life they want. So it's not about putting feelings and thoughts in boxes that some therapy suggests, or some patients have been doing for many years because they think that's the right thing to do. It's about noticing that these thoughts and feelings are entirely normal. We all have anxiety. From time to time, some of us more than others, and that anxiety is there from when we maybe lived in caves and we had to run from saber-toothed tigers or fight them. It keeps us safe. So it's noticing really when that anxiety is showing up or when those difficult thoughts are showing up, and just resting them down so the patient can carry on leading their valued life that they want to live. Next slide. Are you on the...
And just to say, it's 47. So can you wrap up in about 3 minutes? Possible?
I'll try to. So I'll just skip through this. So it's about observing. Sometimes I'll have a small brain in my pocket and just say, just imagine, just watching your brain. Don't need to do anything. Just like a casual scientist, just watch what it's doing and notice those thoughts showing up. This go back one. Not sure why the words aren't there, but it's about helping people notice when they get hooked by difficult thoughts and feelings, because if you get hooked by worries about the future or regrets in the past, then it's impossible to enjoy the present moment. So helping people, giving them a mindfulness script, for example, or signposting them to apps. Thought diffusion is very part of it. So if you're fused with difficult thoughts and they're right in front of your face, you're then unable to see your grandchild, the sunset, for example. So it's helping patients with diffusion exercises, and it can be simple little things like, again, just saying, oh, I noticed there's my cancer story showing up. That can just turn the volume down a bit. Or even singing difficult thoughts. And I know that sounds really weird, but and when I did my training, I thought I could never sing thoughts with people with cancer. But actually, I've had some real success with this. And particularly a person who had a terrible needle phobia and needed a Hickman line. He needed to have treatment the next day. And I thought, what on earth can I do? And I just said, do you think while you're having it, you could sing your difficult thoughts? And when I went in the next day, he said, I sang my thoughts, CNS sang with me, and he had his Hickman line in, and I still see him today and he still talks about that. I normally do sing a difficult thought, but there's no time today, thankfully, for you. So it's very much about acceptance. So that doesn't mean you want, desire, enjoy or approve of something. It means you'll allow it and make room for it in order to do something that you value. And I might use this simple tool of the choice point, helping people look at maybe the moves they're making away from the valued life they want to be living and what helps them move towards it. This is really helpful little tool, mapping out, what is it that's taking you away from seeing your grandchildren? What are those fears, for example? What could help you move towards the things that you want to do? Next slide. And about values, it's not about waiting until you feel like doing something. That's like putting the cart before the horse. So I run a lot. I absolutely hate running. And if I waited until I felt like doing it, I'd never get off the sofa. But I do it because it keeps me fit. I like how I feel afterwards. And hopefully it'll keep me out of a care home. But again, it's sort of, it's not about waiting till you feel like doing something. And often patients with cancer, they're tired, they're in pain, for example. It's about helping them notice that and still do the things they want to do. So setting smart goals, leaning into the discomfort and doing it anyway. And the take-home message really is for them is you can't get rid of your fears, but you can learn to live with them. And I think that might be the last slide. Yes.
It is the last slide, yeah.
A bit of a gallop, but
sorry to compress your 45-minute
fine.
talk into a much smaller periods, but great that you've had an opportunity to kind of share a little bit about your role, and I think you've taught me a few things about psycho-oncology support, so thank you. Any questions for Alison, or any thoughts, reflections from the group?
No, we've gone very quiet.
I might ask a question then to kick off. So thinking about the sort of integration agenda, and you're obviously running a very sort of specific specialist service. Just wonder about how you kind of communicate and kind of work together with sort of primary care or community-based clinicians in relation to your patients.
Is that me? Or
Yeah.
Well, I've only actually been in the job for 3 weeks. So I know Jo Dowell is on the call. Maybe she can, answer that. I certainly would imagine I will be doing letters to the primary care team, calling the practices, things like that. But if Jo is still there, she'd probably...
I think she's just had to step off, sadly.
Oh, okay.
I'll just step back in. I'm Miss. Sorry, how can I help you? I'm just taking a call. Sorry, that's all right. No worries.
Did you hear the question?
How do we integrate with primary care? Was that the question?
Yeah, was it around that sort of that sort of communication, really, how that works, and I guess your thoughts about how we could do that better, that kind of integration, particularly around communication. But not to put you on the spot to find all the answers.
No, that's okay. That's okay. Obviously, we've got access to some of the systems as well, but we work really closely with one of the community matrons, with the community team. So we attend their complex care meeting, we attend the Mountbatten meeting, and obviously we're really lucky. Pam Kay is sitting there quietly on the call as well, and helps that integration with primary care and that crossover of communication from secondary care to primary care. So although everybody hasn't got access to all the systems, we're sharing all the knowledge and all the contacts we have with secondary care. And if we're linking into a patient in the community, we'll make sure all the teams in the hospital are involved in that, so we're working closely together. And any patients that we see, we update primary care as well. And to be honest, I think when I was a CNS in the hospital for about 15 years, if I went back now, I'd be very different with all of the community links and the primary care links and the, social prescribers and the cancer care coordinators. We work really closely with them, because I think we used to just phone up the GP, and you think about all the valuable roles that are in primary care and community care that are supporting the patients and their families. So I don't know if that answered your question, but we kind of make sure that we represent at their meetings. And also, if, like, for example, if we go to Mountbatten meeting every week and the community nurses are there, if there is a patient specifically under one of the CNS teams in the hospital, they will also come to that meeting and share their knowledge about that patient. So we've still got lots to learn, but we've made ways into it. But I don't
For
know if
me,
Pam Kay's on there.
I think it
Yeah,
makes
it's a local
it really
hospice.
exciting. You know, it's such a unique team in that it does that linking between primary and secondary care, and I think it's really exciting and really important. I'm very lucky to be involved.
Yeah, and I think if I went back, I think every CNS team in the hospital should have a CNS that works 2 days in the community and with primary care and visits people at home. I would work very differently, I think. Yeah, and I don't know if Pam Kay's on the system, because she does a lot of the linking in, supporting and education with primary care. If she wants to add anything.
Not much to add, really. I think you've said it, but we are just about to promote all the education links that Jo was just referencing via some education meetings in the evenings for practice nurses. So they're starting November and running through Tuesday evenings and then again in January. So that's their events that are being held at local hotels with supper as a nice way to end your working day. And we'll be looking at ways of all working together across secondary and primary care.
Well, sounds like some great stuff going on, I think. So any more questions from the group or any other comments? I can see some nice comments in the chat, people saying thank you for a really informative presentation. A couple of people needing to leave. Getting the thing around integration being a kind of key part really of the service. I think that's inspiring to many.
I just want to say we couldn't do it without all the teams that are involved in the care already. So it's working alongside them, not kind of instead.
Absolutely. Brilliant. I want to thank our 2 and a bit speakers today. Thank you for sharing about your service. I'm sure you'd be amenable to emails if people got questions.
Absolutely, yeah.
Brilliant. And we'll be sharing the slides or have contact details on them, so people can make those connections if they would, if they've got further things they'd like to ask.
Yeah.
It's just a few things around the group really now. So thanks to speakers. Thanks for coming today. We've got a new website where we'll be hosting resources and links on the slide here. So when you get the slides, obviously you can go straight to the website. We'll be editing the recording and then putting it on there. But you can also see our sort of back catalogue of recordings as well. So we've transitioned the London-based recordings to Essex, so all the previous meetings are available. So if there's previous topics you want to take a look at, or it didn't make it to previous meetings, there's a whole wealth of really interesting presentations and discussions there that you can tap into. And then finally, you can contact me if you're not on the mailing list already. If you've just had the invite passed on to you today, but you're not on the mailing list, drop me an email. Not today, because my email is full due to some IT problems. To give it a day or two, and then drop me a message. Or if you go to the website, there's a contact form there as well. Also, I can see some things in the chat about this. Absolutely, we will do. Also, just to say that I think we've probably lost some members in the transition from the hosting arrangements for the group. The group remains unchanged. It's a national group. So please do tell your colleagues about our meetings if you've enjoyed it today and enjoyed previous meetings, and help us get our membership back up. So we have a vibrant and chatty sessions when we do meet. You should have dates in your diary for December and March. Obviously, we'll be planning beyond that. We're still looking for speakers, so we do have some stuff lined up, but there's still some gaps. So anybody on the call here, if you've got a project that you're working on, you know of an interesting project, if it might be of interest to the group, then drop us an email and we'll make contact. I think that's everything I want to say today, except thank you for coming. Thank you for your participation. And thanks again to our amazing speakers, who, particularly Alison, who stepped in at the last minute, really, to speak. So very much appreciated.
Pleasure.
Thanks, everyone.